Okay, let's start on time so we can finish on time. You guys have a small study, small group. Okay. Yes, I am in one of, but there are several small groups, I assume, right? So I will be in one of them. I don't know which one. So today we have this lecture on race in nephrology. And all the lectures that you saw or you are going to see later days, I have been teaching them for many years. Over time, they have changed, obviously. It is not 1 year that I don't change some of them. But this specific lecture, I just made it a few years ago, 3, 4 years ago, since the things changed. So this is kind of a new concept in nephrology. You are going to deal with it one way or another, and it is beyond the USMLE. It has some elements that you can use in the USMLE and other settings, but in general, it's something that we need to know about in nephrology and medicine. So these are the learning objectives. Let's start with the question. This is the question. Which of the following is more likely to be correct regarding renal function? And this is made up by me. So it is not a standard, it's not a good question, but it is for educational purposes. In patients with kidney disease, using EGFR creatinine is preferable compared to EGFR cystatin C. In the general population, removal of ancestry but not race is recommended for estimation of renal function. Removing race from EGFR in CKD-AP equation is likely to increase the number of Black patients diagnosed with kidney disease. And last, serum creatinine is a more accurate marker of renal function in those patients with extremes of muscle mass. Think about this. You don't have to answer this. We are going through some of them I hope is so gibberish to you, you just don't know what to make of it. But think about it and we come back to this question. That's something that looks odd to you. You will see after 45, 50 minutes, it's such an easy question. And then you feel that you have achieved something during this hour, hopefully. Remember, this is the day that we start the planned repetition. We'll have a lot of things that you already know. I'm just repeating them. This is what we talked about. Kidney is a sophisticated filter. We start from the blood one side, primitive urine comes here. It is pushed into the primitive urine is made here. These are the three layers. What are the three layers, guys? What is this? We are on the side of the blood yet. Endothelium. We are on the side of the blood. It's endothelium. It's the vessel, right? Fenestrative endothelium. What would be this one? GBM, right? Basement membrane, glomerular basement membrane. And what would that be? Podocyte. This is the podocyte, big epithelial cell. Does that make sense? So the urine is made. Then the urine is going through a lot of changes in the tubules and we get the urine. You remember? So we go from the blood all the way to the urine. That's the job of the kidney, right? So we talk about the byproduct is it, and homeostasis is the product of the kidney. Okay. How can we evaluate renal function? You know it. Filtration process is the main one, so everything parallels with that, and it happens in the glomerulus. So GFR is the standard for assessment of renal function, and the total of the total volume of filtrate passing through the glomeruli each minute. Basically, every minute, how much of blood is filtered out of creatinine, BUN, whatever that we are looking at. GFR, we use it for that purpose. And I put this for University of Florida people because we also have a GFR in Gainesville, but that's Gainesville Fire Rescue. So we all the time when I see them in the streets, I think of the kidney. So why is GFR important? Normal is more than 60. Do you remember I showed you a table? I told you with age our GFR tends to go down, but never goes below 60. Do you remember? Normal GFR is never less than 60. Aging or whatever cannot bring it less than 60. 60 milliliter per minute. For most of us, hopefully, is around 100, and the higher, the better, the majority of the time. It guides many clinical decisions. For example, for dosing of the drugs, we use GFR, pain medicines, radiocontrast agents, and all those. Referral to a specialty care. The insurance will not pay everyone unless they have certain GFR that is low if they are referred to me. You cannot refer to me a patient with a GFR of 75, right? More importantly, I put two stars here. Referral for renal transplantation. I should look at the GFR of the patient and say, hey, I think it's time for you to be evaluated for kidney transplant. But if the GFR is 40, it will be removed. They should have, for example, to be on the list to get evaluated, they should have a GFR of less than 30. And it is after GFR of less than 20 that they are considered for transplant. So they need to have a low GFR to be considered for transplant. Timing, planning, and initiation of dialysis. So I'm following somebody, the GFR is coming down over the years. Where do I decide, hey, it's time to start dialysis? It's based on GFR. So I'm just telling you the importance of GFR, how GFR is important in different situations. And enrollment in clinical trials. I want to try this medicine versus this medicine. I want to know what is the impact on the kidney. The criteria for inclusion will have GFR. If patients have GFR between 25 and 85, we put them. If it is beyond this, we don't. So GFR is important in many, many settings, clinical decisions. Remember how we can assess GFR? We said we need compound X. And then we said the higher in the blood, less filtered. The lower in the blood, it has been filtered very well, right? Remember, we said that it should be present in the blood all the time, freely filtered, and not transported in the renal tubules. Did we say that creatinine was a good option here? What was the downside of creatinine? Do you remember? Secretion. How much was it? Was it 90%, 50%? Not much, 10, 20%, right? A little bit of the creatinine is secreted into the tubule in the proximal tubule. So do you think the urine creatinine that we have here is more than what was filtered or less than what was filtered? More. Something has been added to it in the proximal tubule. What about urea? Urea will be good. There is no transport. Would you agree with me? Right? Don't agree with me. I am wrong. Urea was absorbed 10 to 20%, the opposite of creatinine. 10 to percent of the BUN or urea that was filtered will be absorbed. So the urine urea is less than what was filtered or more than what was filtered? Less than what was filtered, right? Some of it has been absorbed. Okay. So now we say the GFR can be measured in two ways. One is that we use something from outside, we inject it to the patient, we know how much the serum level is, then we see how much is in the urine. The difference would be the filtration, right? So, from the measured clearance of exogenous filtration markers, we call it measured GFR. This is perfect GFR. This is really the most objective way to calculate GFR. Second is to estimate it. It's not measured. It to estimate it from something that is already in the blood, like creatinine. Okay, this one we call eGFR, MGFR, eGFR. Measured would be the standard, but we will see that it is not always easy to do. So we go for the next one, which is estimation instead of measurement. In the exogenous filtration markers, two of them that you need to memorize are inulin and iothalamate. These two will be injected into the person. Then we see how much is in the serum, how much is in the urine. We get the exact filtration rate of the kidney. So inulin clearance continuous intravenous infusion we give is the gold standard. So if I ask you what's the gold standard for measurement of kidney function, you will say inulin, which is uh, exogenous. We inject it to the patient. There are other ones I just put here for you to know, but the two that you need to know is inulin and iothalamate. So again, remember that it's not absorbed or secreted. So it comes here, goes all the way here. Perfect measurement for filtration. For the endogenous ones, you remember about creatinine, it is in the muscle and all those. I had told you about it so much that you know it very well, but I didn't tell you about cystatin C. Cystatin C is another endogenous marker that we didn't talk about that has been the focus of a lot of attention recently. This is the difference between creatinine and cystatin C. Again, it's kind of a larger table, so I suggest you remember at least the parts that I put for you in green. So just to memorize, not just to have an overview, if I can find the cursor here. Okay, that is creatinine is a small amino acid is coming from the muscle. We talked about it. Cystatin C is coming from all nucleated cells in the body. Okay, so creatinine is filtered and a little bit secreted. We talked about it right a few minutes ago, 10-15% or 20% in the proximal tube. But cystatin C is not secreted or is not absorbed. That's a perfect endogenous marker. Okay. For creatinine, we propose non-renal determinants. Age will affect it, sex will affect it, race will not affect it. And we are going to talk about it in a second. And muscle mass will affect it. Age and sex will change cystatin C, but we don't have anything about the race or muscle mass. So if I have a muscle mass is a big thing, it will change my creatinine, but it doesn't change my cystatin C. Or if I am in the ICU for 2 months, I have lost all my muscles, my creatinine will be artificially low, but my cystatin C will stay the same. So it is not um, dependent on the muscle mass. Cystatin C is really good. So again, alteration in muscle mass changes creatinine. Cystatin C is independent of muscle mass. Well, thyroid function and steroid use might change cystatin C. It has its own downfalls, but it is much better than creatinine. Last but not least, creatine is inexpensive, has been used for decades. Cystatin C is kind of expensive. Okay. These are the changes. So cystatin C is by far better than creatinine. The problem is that it is expensive. Right. So not everybody has the resources to use it. Okay. We talked about the fact that creatinine on its own, if it is not good enough, because it has something to do with the GFR not being linear and dependent on the renal parameters. How should we do it? We use some formulae to make it estimated GFR, to go from serum creatinine to estimated GFR based on the formulae, to put into account these, I would say, shortcomings of creatinine. There are three different formulae: Cockcroft Gold, MDRD, CKD, AP. They go from serum creatinine to estimation of GFR. Each of them puts into account some different factors. Cockcroft Gold, what it puts uh, in the equation would be age, sex, and body weight. You remember I told you Cockcroft Gold, the pharmacists love it because it has weight in it. So all the dosing of the medicines will be per kilogram, right? It's good for the kids, for the adults. So the pharmacists still use it for, uh, it is here written, age, gender, and weight, right? This is really good. This is what you need to know. The rest of it is for your information, including the formula. MDRD is really great But one thing that it is from 1,600 patients, it was derived from that study. So something you should realize is that it was derived from a group of patients who already had low GFR, 39 was their average. So it is better for patients with CKD than the general population. This is number one. But more importantly, when you look at the formula, something comes into your attention. First of all, only 8% of those people were blacks. So it is validated mainly for non-black population. This is number one limitation. Number two, probably more important, look, when it is calculating whatever they put, creatinine, age, whatever, then they multiply with 1.2 if you are black. They tell you, you know what? If you are black, you have more muscles. So we give you 20% up. 1.2. This 1.2 has been a matter of a lot of discussion. So they said, hey, blacks have more muscles in general, so we give them 20% higher. If I have the same serum creatinine with the age, with everything else, black versus non-black, this one comes with a GFR of 50. The other one comes up with 60 because I gave him 20%. With the same serum creatinine, I tell the black guy, hey, you have more GFR. Your GFR is better than this guy that is non-black. Okay? So we keep that in mind. We come back to this. CKD-EPI is the newer equation, and it is considered to be better in many ways. One of them is that in higher GFRs, it is closer to measured GFR. So in higher, for the general population, for epidemiology, the name goes with it. This is better than MDRD. This is number one. Remember, MDRD was derived from a population that the average GFR was around 40. So they had kidney disease. This one has come from people that, for the general population, so CKD-EPI is better. But more importantly, they had added race in it, 15% that they have removed. So age, gender, and race can be included in it. But then we have removed the race. Recently, we are going to talk about it. Age, gender, and race. Remember, I told you yesterday or the day before, I repeat it. MDRD and CKD-EPI have the same factors in them. Age, gender, race. It's Cockcroft Gold that has weight in it. It's different. These two are similar to each other. Limitations of creatinine-based assays. Number one is that it is dependent on muscle mass. If I don't have any muscles, my creatinine would be artificially low. You will think, wow, great kidney function, but it is not true. I don't have muscle, right? On the other side, if I am very muscular bodybuilder or in a great shape, my creatinine is high despite the fact that my kidneys are perfect, right? So it depends on the muscles. That's number one. Then there are some drugs that decrease that 10 to 20% secretion, right? So it increases the serum creatinine artificially. Like one of the very common antibiotics that you and us use is Bactrim. Have you heard of Bactrim? For UTI, many people use it. That stops the secretion of the creatinine in the proximal tubule. So the serum creatinine goes up artificially. Number three is the population that were not well presented in the cohorts. African Americans were not, and all the ethnic minorities were not represented in these formulae. Make them make their use a little bit tricky in for everyone. And also this includes elderly population. Okay. Do you want to give a question to yourself to boost up your energy? And this is a real case. You see, I even put the actual labs that I see so you don't see that, you don't think that I made it up. So I have a 26-year-old man. I had just saw this patient last year in my clinic, March of 2024. 26-year-old man with no past medical history is referred to you for a low EGFR of 56.7. Here we are, 56.7 estimated GFR based on serum creatinine of 1.7. Okay. He plays basketball 3 times a week and uses supplements to get more muscular. What is that supplement that they use to get muscular? Creatine, right? Okay. What is your recommendation? He's too young to have kidney disease. Further investigation is unnecessary. Two, EGFR equation may have been MDRD. We need to redo it with Cockcroft in this age range. Three, check cystatin C to evaluate his kidney function better. Four, he needs to stop basketball but would benefit from continuing supplements. Which one would you go for? You go with three. Anybody who wants to use another one? One, two, three, four. You don't have to. I'm just asking. I hated again the professors who pinpointed somebody and said, "You tell me." I don't do that to you. If you want to answer, you do. Perfect. Yeah, I think three is a good answer. He's too young to have kidney disease is nonsense. You can have a kid. You can be a kid and have kidney disease. So forget about that. EGFR equation may have been MDRD. We need to redo it. Cockcroft is good for what we said? Drug dosing. It has weight in it. So Cockcroft and MDRD, no, I don't think that Cockcroft will do anything to it. And Cockcroft is outdated. Nobody uses it except for that specific indication. Otherwise, Cockcroft, most people even don't know it. Check cystatin C. Yeah, if you have a 26-year-old that is playing basketball, is taking creatinine to be muscular, it is possible that the serum creatinine is high because he has a lot of good muscles. Good for him, right? That's it. He needs to stop basketball. That's nonsense. Okay. So should we check cystatin C in this patient? Let's check it. Actually, I checked it. Cystatin C is 0.82. Cystatin C is like creatinine. Around 1 is normal. Think about it. Creatinine says 1.7. Cystatin C says 0.87. What does that tell you? This was all about his muscles. His EGFR by cystatin C 116. Does that make sense to you? So I showed you something in action. All the hypotheses that I tell you, all the mumbo jumbo theoretical things, that's something in action that you see in clinical practice. Cystatin C helps us differentiate real kidney dysfunction from good muscular mass. Does that make sense? In this patient, that's what happened. Perfect. So again, race and EGFR. Here we say cystatin C. These are the things that can affect cystatin C. Thyroid dysfunction is here, diabetes is here, and smoking is here. For creatinine, muscle mass is a big deal. Then age, sex, ethnicity, I do not agree, and most people do not agree with it anymore. Age, sex, muscle mass. These three most people agree. Ethnicity has been a matter of discussion. And both of them can give us estimated GFR using any of those formulas, MDRD, or even better, CKD epi. Take a look at MDRD. It gives us some insight, going a little bit deeper in MDRD. So MDRD came out of three small studies that were published in 1970s and 1990s. Black persons, they came up with this conclusion. Black persons have greater muscle mass than white persons. The first one was the body composition of roughly 240 black and white children, and called that black children had lower body fat and different body densities. Second, the study looked at about 40 adults only and said blacks had higher total body potassium and calcium compared with whites. Third one looked at 60 healthy hospital workers and concluded that blacks had higher serum creatinine kinase CPK levels. Basically, what I want to say here, you don't have to know the details. It is based on weak data, not strong data. That's all I need to say about the MDRD coming up with the idea that all black people have more muscle mass. That is not necessarily true. Pitfalls of using race, also, I want to mention this. You have seen this rice is not a biology construct in many of my slides. So keep that in mind. Sociologists think that race is arbitrary. If you tell me, Amir, you are Iranian, how much of you is from which genes? But I can't say how much of me has come from North Africa, from Europe, from any Middle East. I don't know, right? It's over the years it has been mixed. So telling somebody black versus non-black, it basically doesn't give you the whole spectrum. That's the whole. It leaves the gray part, the main part out, basically. Right. Studies comparing the self-reported race with ancestral. When you say ancestry, you're looking at the genes. When you say race, you are relying on what I am telling you. Right. So this is the difference. Ancestry is very, very correct. It's the gene level. Race is something I am telling you depending on the color of my skin. So it can be completely wrong. Studies comparing self-reported race with ancestral genetic markers suggest that nearly a quarter, 25% of the ancestry informative markers, individuals who identify as black, are of non-African origin, actually. Just to give you an idea. Race as a social classification system must be distinguished from ancestry, which is the genealogical history, which are the genes. Basically, don't go by race. There are questions about when you just say, oh, you are black, so add 20% to your GFR. Is it just overestimation of your GFR? Am I doing you a favor or not? Something that we need to keep in mind when we talk about the pitfalls of race is that including the coefficient for race, the 20% that we increase for black people, what happened is that it just ignores the substantial diversity I just told you about. How many percent of my genes are coming from where, right? So within the self-identified black or African Americans, there are observations that it does not improve the accuracy of EGFR. Most important concern, it increases the inequity. What it means is that, you see, think about it. I have two patients, Mr. White and Mr. Black, my patients. They have CKD because they have had hypertension, diabetes, and also their GFR is coming down. It's coming down, it's coming down, coming down. 30. It hits 30. So I am sending these two for transplant evaluation. But wait a minute. For Mr. Black, I say, hey, MDRD says, I have give you 20% increase in your GFR. Your GFR, because you have more muscles, it is artificially high, your creatinine. It gives you bad GFR. 30 plus 20% of 30 is 36. So you are ineligible to be sent for transplant evaluation. Mr. White, you go for transplant evaluation. Mr. Black, you stay with me. We wait a few more months or a year or two before you are eligible. Do you see the difference? Yes. Another thing, the GFR of less than 60. Let's say those who have GFR of less than 60, they are eligible to get nutritional advice for free because they have CKD. Mr. White has GFR of 60. Mr. Black has GFR of 60. I tell Mr. Black, hey, it says 60 for you, but you are 60 plus 20%. You are 72. You are ineligible for nutritional advice that is free. But Mr. White, I'm sending you for nutritional consult. Do you see the difference? So when you get that 20%, at first it looks that, oh, you are giving them more GFR. You are diagnosing them with less CKD. It is true, but you are eliminating some of the services that they could have received. Does that make sense? That's the point. So why is GFR important? We talked about this. Look at the renal transplant that I had put in red with two. This is, and I gave you the example. This is how the equations came. The first one was Cockcroft-Gault in 1970s. Then we had more and more. MDRD was next. CKD-AP is more common. CKD combined, meaning that both cystatin C and creatinine. You go cystatin C. Sorry, CKD-AP based on creatinine, CKD-AP based on cystatin C, and you get the average of these. That would be the best one and first call for. Starting 2017, there was a first call for race removal from EGFR equations. You see, this is all new happening. And in 2020, more calls for race removal. If you remember, in US, there was some issues with the societal issues that there were. So the point I want to make is that the call for race removal has been started, let's say, some 10 years ago. To this day, there is a debate. I want to tell you, there are some people that we should not remove race, that there is a difference biologically. But I will tell you what the recommendations of the guidelines or the societies are telling us. Think about removing EGFR, how it impacts the population. I told you with an example, I show it now on a diagram. Here, this is a population of ESRD, chronic kidney disease patients. They're all black. In blue, that's their GFR. The majority of them are around 100 or something, and there are two sides. As soon as you remove the GFR, as soon as you remove the race from the formula, you remove that 20% extra that you were giving them. So do you think the GFR will go towards higher or lower? Will go towards lower. So that black population that was blue is pushed a little bit downward. So now everybody will get less, 20% less of GFR. Okay? The same is on this side. Blue is with race, orange is without race. You see, the orange has gone to the left. Removing race from EGFR increases the number of black individuals diagnosed with kidney disease. Would you agree with me? Because if I tell you anybody with a GFR of less than 60 has kidney disease, so far I was giving you 20%, you were above 60. Now you go below 60, right? So that's number one. Study estimates increasing prevalence of CKD from 5.8 to 10.4% in blacks in US. And rigorous examination is needed. Okay. 2021, American Society of Nephrology and National Kidney Foundation came and said, you know what, it's too much of just everybody says their own thing. Let's get together, have a committee, look at all the data, and come up with some recommendation that everybody will agree. And ASN is the highest authority in the field of nephrology, American Society of Nephrology. Okay. In August 2022, you see that. Okay. This is what they came up, a unifying approach for GFR estimation. Recommendations from National Kidney Foundation, American Society of Nephrology Task Force on reassessing something. Okay. Three important things that they told us. Number one, for US adults, 85% of them have normal kidney function for the whole general population, basically, right? Immediate implementation of CKD epicreatinine without race. So they say, number one, don't use MDRD, use CKD epi. You can use creatinine and you should remove race. Three different recommendations in number one recommendation. CKD epi without race, using creatinine. This is for who? For the general population who have 85% of them have normal kidney function. Okay. So here, for example, if you go to, let's put CKD epi formula, this is probably one of the first ones that come in Google. CKD epi creatinine equation without the race variable, meaning that CKD epi is there. You put gender, age, creatinine, but you remove race. It is removed in the new calculators. Gender, age, serum creatinine you put, and it tells you what the result is. What about the second recommendation? Second recommendation is for you, for me, those who deal with patients with kidney disease, not for the general population. They say for these people, use cystatin C. Creatinine does not cut the deal. It too much changes with the muscular mass. Okay, so for me, they say try to use cystatin C, especially to confirm EGFR in adults who are at risk or have kidney disease. So even if your kidney is completely normal with creatinine, I probably still will check cystatin C to because if you are at risk, right? It's not necessarily somebody who has kidney disease. Anybody at risk. Why do I say this? Why should it be a good idea to check cystatin C for these people? I just want to check with you one study. It needs a lot of your focus. I have to admit, it is a little bit tricky to understand. So they looked at patients, and this is an NEJM paper in 2021. So this is patients with chronic kidney disease. They looked at age, sex, creatinine, or cystatin C. They looked at both race and ancestry. It is really very, very nice paper, but really difficult to understand. So, in patients with chronic kidney disease, they compared measured GFR gold standard. You remember? Iothalamate they used. Iothalamate, IGFR or MGFR with EGFR. They compared EGFR to IGFR. Creatinine based versus cystatin based, with and without race and ancestry. So they put a lot of different factors to come up with some good results. Look at this beautiful, beautiful thing. Okay, here you have this is creatinine. All of this is creatinine on this side. You have serum creatinine, age, sex, African ancestry. Creatinine, age, sex, race. Creatinine, age, sex, nothing. So this is removal of race and ancestry. The rest is the same. It is looking at the difference between the iothalamic GFR and estimated GFR by CKD-AP. So in I would say ideal world, the measured GFR and EGFR should be exactly the same, right? That's what you would love, that the difference would be zero. The more difference they have, the less accurate your EGFR is. Would you agree with me? Keep that in mind. Look at this. If you look creatinine, you put ancestry with all these, both of them are here. Reasonable, but not great, but they are still okay. If you put race, good. But if you remove race or ancestry, they go two different ways, right? They go two different ways. In blacks, it goes up. In non-blacks, it's actually going down. The difference between the measured GFR or iothalamic GFR and EGFR. If it was they were next to each other, zero would have been great, right? That's for creatinine. So removal of race and ancestry messes up the creatinine formula. What about the cystatin C formula? This is cystatin C. Same concept. Ancestry, race, nothing. Cystatin C, cystatin C, cystatin C. This side, they are different. This side, they are different. You remove ancestry and race, and it does the job. That's why they tell the nephrologist, use cystatin C and don't use race or ancestry. Perfect. Using serum creatinine level, age, and sex alone underestimated EGFR in black participants, but not in non-black participants. In patients with CKD, cystatin C-based EGFR might be more accurate than creatinine-based EGFR. General population, creatinine does the job. For nephrologists, we need to use cystatin C. Again, remember, cystatin C is kind of expensive. At the University of Florida, it's only 2 years we have started to use it. Some centers don't have it. Okay, that's the basis for this second thing. And the third one was just do more research for the future, nothing really big. So the first and second one are the important ones. So here you see for the CKD population, general population was CKD AP I showed you. For people with kidney disease, use either cystatin C or a combination of creatinine and cystatin C. And again, do not use race. Use gender, age, serum creatinine. Ideally, CKD-AP, cystatin C alone or with creatine for CKD, CKD-AP, creatine for general population. That's the ideal. But again, in real world, CKD-AP creatinine is used for most people because cystatin C is expensive. But again, some centers like us, we have started to use it, and some centers actually started before us. So if you look at the potential implications of removing race from EGFR, look at here. This is for the diagnosis when the GFR is less than 16. Look at the estimated impact. 1 million black adults will be newly diagnosed with CKD. You know it now, right? Because the 20% artificial boost that we were giving them is taken away, right? You would think that it is good or bad. I leave it to you. They are more diagnosed with CKD, but then also they get the services that are associated with the diagnosis. So it's really depends on how you look at it, right? Referral for nephrologists. You cannot refer in some systems if the GFR is over 30. So many of the black people will not be referred unless you remove the race from the EGFR. The EGFR would be less. So referral to nephrologists, an additional 68,000 black patients will be getting referral to a specialty. Or where is the as a nephrologist. Yeah, kidney transplant is here. An additional 37,000 black patients will have timely access to transplant evaluation. That's what I was talking with you about. The GFR of less than 20. Health insurance also is on that side of it, actually. So more people will have a, I would say, will have access to quality nutritional thing, but more patients, more people will have underlying condition. So let's go to the question that I made at the beginning. See if you are comfortably answering the question without any doubt. Which of the following is more likely to be correct? In patients with kidney disease, using EGFR creatinine is preferable compared to EGFR cystatin C. Would you agree with this? Isn't it the opposite? It's the opposite, right? It's the opposite. In CKD patients, cystatin C. In the general population, creatinine. Two, in the general population, removal of ancestry, but not race, is recommended for estimation of renal function. Do you think it is true or not? Both of them are. Removing race from EGFR in CKD-AP is likely to increase the number of black patients diagnosed with kidney disease. Do you think it's true? She doesn't agree. So let's read it again. Removing race from EGFR equation in CKD-AP is likely to increase. Aren't we giving them a boost 15 to 20%? Removal of it will make them more diagnosed with CKD because their GFR goes down, right? So it is true actually. Fourth, serum creatinine is more accurate marker of renal function in those patients with extremes of muscle mass. Would you agree with this? Completely false. It's actually the most inaccurate in the extremes of muscle mass, either supermuscular or emaciated. Believe it or not, the story of new EGFR equation and removal of race was one of the 10 stories in 2021 that made a big deal in the nephrology community. And with this, I'd like to thank you for your attention today. We'll talk about CKD and ESRD tomorrow.